Okay, let's recap. We're gonna go ahead and jump into this outline. I do ask that you guys are writing into the chat, and then I also already have an outline that's filled out. So as you guys say what I already have, I'm gonna copy and paste it over. Okay. So what can insensitivity lead to? What can happen if we're insensitive regarding our patient's culture? Yes, it jeopardizes their safety. Good job. And they're stressed. Exactly. Yeah, we can also offend them. And it just leads to that lack of trust, reduced compliance. Yeah. All of those are accurate. Okay. I do like the reduced compliance, stress, stress. Patient is offended, jeopardize patient safety outcomes. Oh, Joseph. Hey, Joe. Reduced compliance. If we're talking about the importance of sensitivity, why do we want to be sensitive? What does it do for our patients? Okay. Do we know? If we are sensitive, we can actually do the opposite of what insensitivity does, right? So that means that we can improve their care and their outcomes. It does build rapport. Good job. Yeah. So when we're talking about being sensitive, we're talking about improving their care and outcomes. We're addressing health disparities. We're building rapport. Okay. And then again, building rapport, better compliance because they trust their care team. Okay. Pretty straightforward. Now we're gonna go into the next topic. We're talking about cultural knowledge. So, um, I'm gonna go ahead and just copy and paste this because I think it's all pretty straightforward. So this is where we're seeking knowledge about the culture that we're working with. And again, it's to build that trust and rapport. And then if we have lack of knowledge, it can lead to mistakes. There's actually a pretty specific example. I don't know if you guys listened to her audio in her lecture. Um, but do we remember any examples of a practice of a different culture that, like, if we don't have knowledge of that culture, then we wouldn't really know? um yeah, pointing, exactly. Like if we aren't aware that that's a cultural practice, we could mistake it as harm, right? So that's important to know. Let me figure out how many copies this is. Pointing, so that's when the bot they yeah, and cupping. Okay, Alexis, glad you joined us. So then we also have cupping. Okay. Because I have work to do. Okay, so so coining is a Cambodian practice, and then cupping is usually in Southeast Asian countries. So that draws out the impurities from the sin, and then also just to note, the placement of the cup usually indicates like the issue or the desired area of healing. So pretty straightforward. Um, this is what I was talking about. The next bullet point that I have is just um where we talk about lack of knowledge. I believe, and I could be mistaken, but I remember in the audio, I think she talks about um something is like mistaken for like child abuse, I think, and a dad actually commits suicide. Is that accurate? Does anyone recall that? Maybe, maybe not. Yeah, so I remember hearing that. Yeah, so with the coin. And then another example in her PowerPoint is that if we don't have like knowledge of our patient's culture, like the foods that they can or can't eat, but we still provide insulin coverage to them, it actually puts them at risk of hypoglycemia, right? So that also plays a role in being like culturally competent and safely caring for patients. Okay, so that concludes cultural knowledge. We're going to go ahead and move down to cultural awareness. So how would we she says pretty specifically, like, how do we define like cultural awareness? Do you guys remember? What can we do as nurses to be aware? Does look inward sound familiar? This is where we're um this is where we're recognizing our own biases. There we go. Thanks, Diane. We're recognizing our own biases and removing unintentional influences. We're looking inward. Yes, you guys got that one. And then do you guys recall what the ethnocentric tendency refers to? I know maybe we didn't get it in the PowerPoints, but the ethnocentric tendency is when we're yes, good job, Dan. You did study. Did you say you studied this weekend? You're doing great if you didn't. Um, it's where we judge others by using our own group as the standard. Um, and you can actually impose your own like beliefs, values, and patterns of behavior. Oh, was this content on that exam for culture? For community, I mean? I thought it was only up to like health teaching. Oh, I see. So you're ahead of the game. Got it. Yeah. Okay. So then that is the ethnocentric tendency. Um, I do recall this being something you need to know. Okay. So it's when we're using our own standard and we're imposing our beliefs. When we're talking about cultural considerations. So one of them are space and distance. Do you guys recall what cultures like prefer more space versus less space? Do you guys remember that from the lecture at all? The US likes what? Yeah, more space. Mm-hmm. I also have Great Britain and Canada for some reason. And then, yep, great. And then do you guys have an example of who like really isn't bothered by having more space? Like they are okay with less space? Yes, Asian communities and Latin America. Okay, you guys are doing great. We're cranking on through here. Um, when it comes to Middle East, I don't know, I might have missed something. I can add it though. Okay. So when we're talking about eye contact, um, do you guys remember what she said about eye contact? Like certain countries could see it as being disrespectful or rude. Yeah, yeah. Mm-hmm. That's correct, Kayla. So like the interpretation that I got, and again, these are in my notes, so I'm assuming it's in her audio somewhere. But the interpretation that I got is that like in America, like eye contact would be seen as like confident or engaged, like when we learn about public speaking and everything, whereas or like a sign of respect, whereas in Asian countries, it's very disrespectful to hold eye contact. So just important to know, there's there's like a practice question I think where it talks about like, oh, the patient's like looking away, not making eye contact, something like that. And some of the answers are like, get in front of them so that they can see you and stuff like that. So just be aware that if you do read something like that, this is where we're looking at our cultural considerations, okay? When it comes to time and punctuality, um, says that some cultures might view not being on time as rude, while in other cultures, running late might be expected. So just know that those are just like considerations. And then the big one that we need to know, especially as nurses, is pain. Okay. So does anyone remember the cultures that are like more stoic when it comes to pain? Hispanic, and one more. Asian. Bye, yeah, so they can be very stoic. They don't want to draw attention to themselves, and that leads to pain being unreported and undertreated. Okay, moving on down, we have our cultural variation. So I'm actually just going to go ahead and copy and paste this whole section. You guys can read through it. It's really just going to be memorizing it. Um, I don't remember there is a a question or two about something here, about one of these specific variations. But it's really just memorization. So Mongolian spot would be African, Asian, Latin, and then diabetes, Native American, lactose intolerance, Asian, Hispanic. I don't remember anything too specific in here, but just knowing that there are medication variations based on like the ethnic group and how it affects them. There might be lower doses, like in the example of psychotropic meds. Okay. Um, important to know. There are like three bullet points that they talk about when it comes to health disparities that can occur from ineffective provider communication. Does anyone recall what those might be or one of them? So, like, what would happen if there's bad communication between the patient and the provider? Med error? I mean, you're not wrong. It's more about like if we don't have, yeah, like not returning no follow-up, yeah, something like that. So like the client really isn't going to be participating in their decision making. If we don't have that communication, if we don't have that relationship built. The other two are just like inappropriate or negative interpersonal styles. So um my formatting. And then just lack of cultural competency. So we do want to make sure that we're being culturally aware. We're taking all of our considerations into account. Okay. Um, there's a slide on like what do patients look for in a nurse. Why do you guys feel that patients would want a nurse of the same culture? Can relate to more, they understand the culture. Yeah. Comfort, understanding. Yeah. Even when it comes down to like possibly speaking the same language, like that's important. So you guys hit them all, more likely to understand issues that might be specific to their race or culture, and then comforting for the provider to be of similar backgrounds. They also want a nurse that likes them. We've said this a couple times. I know it gets a little repetitive, so I'm just going to go ahead and copy and paste this. But they're more likely to adhere to treatment. They come back for their services, and they'll be more likely to be compliant. And then they're more likely to be non-compliant if they feel that their care team doesn't really care for them. Because why would they trust that you have their best interests in mind if they don't feel like you care about them, right? That goes into many facets of life. Okay. Um, I think we're almost done with community. Yes. So we are going to talk briefly on different health belief systems. So there's magical religious. Do you guys remember the example that she put out there for the magical religious? This is a slide with Evil Eye. Yeah, good job, Christine. Um, so this is like the belief that someone can project harm by gazing or staring at another. Um, and it's a matter of like evil spirits. I think it can also be known as mal de ojo. I know my mother-in-law got my son like a red bracelet to protect him from that. They also touch on like the treatment within this belief system would be shamanism, and then that's carried out by like a healer practitioner. They're also known as medicine man, kahunas, santeros, or spiritual healers. They remove the harmful spirit from the body, restore energy, and then um, they have the power to retrieve the lost soul or spirit of a sick person. So that is all under magical religious. Now we get into scientific. What do you guys remember about the scientific belief system? It's more what we follow, I feel, in like Western medicine. Yeah, there you go. Exactly, Western medicine. So disease and illness are caused by microorganisms or malfunction of the body. Um, this is honestly kind of like the basis of what we're trying to do as nurses, right? We treat the causes. Um, this belief system kind of disavows the metaphysical and holistic. I do want to put one more bullet point that I remember being kind of important, and that is domain for suspense. To caution the arrogance in medicine. Okay. Um, I don't know, I can't remember specifically why, but I remember that being important, so I put it in bold. Um, I'll highlight this. Usually I do try to highlight or bold it. What else did I say? Something over here. Something about this, right? Mm, yeah, I think that's all we've talked about so far that I can really remember. I think that's what we touched on so far. Um, so now we're going to be talking about the holistic belief. Do you guys remember anything about the holistic approach? I don't know why, but I think of like essential oils and stuff. Anyone in the chat? What is our holistic belief system? Even if it's just an example of it. Yin and yang, yeah. The body is imbalanced. Focuses more on mind, body, spirit. There you go, herbal remedies. Good job, guys. Again, all pretty straightforward. Like if you saw an example, you guys would know kind of where it falls, right? So to be healthy, you must remain in harmony with nature's laws and willingly adapt to the changes in the environment. Mind, body, spirit, not just being sick and being selfish. Good job, guys. Okay, we're gonna go ahead and move. Does anyone have any questions about cultural care before we move into our psych content? Maybe not. Okay, I'm gonna go ahead and proceed. Um, so this is what I got from your guys' syllabus that week 7 covered crisis intervention, human abuse, substance use, and addictive disorders. So this should all be decently fresh in your mind because I think you just learned it last week. So we'll crank it out, okay? So what, how do they define crisis? It's a sudden event that disturbs what? Homeostasis. Good job. It's also when usual coping mechanisms don't resolve the problem, right? Important to note. That's how we define crisis. Now we're going to get into crisis intervention. There are 4 phases. I kind of bolded some stuff out, but I just need to see where you guys are at. Do you guys remember phase 1? Like what happens in phase 1 of crisis intervention? Intervention. I think we're jumping ahead. Oh wait, what am I doing? Why does it say phases? I think it's just phases of crisis. I'm sorry. I did that wrong. This is not phases of crisis intervention. This is just phases of crisis. Sorry about that. Yeah. So that's when there's exposure to a precipitating stressor, right? Sorry about that. My outline's a little different from the one that I had here. So that's exposure to the precipitating stressor. This is when anxiety starts to increase, and then their previous problem-solving techniques are employed. What happens in phase 2 of crisis? What happens to those coping skills? Are they working? Yeah, failed coping skills. Exactly. Um, how do we think our patients are feeling in that second phase of crisis? Anxiety is increasing, anxious, helplessness, hopelessness. Yeah, all of those. Good job, guys. They're also just uncomfortable all around. So discomfort. Coping techniques that have worked in the past are attempted only to create feelings of helplessness when they're not successful and they're confused and disorganized. In phase 3, what's happening to our coping mechanisms? They're gone. Yeah, they completely failed. So, I think it's important to note that, yeah, good job. So this is where some new problem solving techniques can be used. Um, if they work, resolution can occur at this phase, right? Yeah, exactly. There you go, guys. So if any of the new coping mechanisms work at this phase, they will head towards resolution. Um, I do wanna, I think it might have just been a point that I made sure to highlight, but it could also be that they start to look at their problem from like a different perspective or like even start to overlook certain things just to try to make it seem like less of a crisis. I don't necessarily remember that being important for the quiz exactly, but I think it's just good to know that it doesn't necessarily mean that the crisis is being like resolved so much as they're trying to kind of see it differently to not freak out as bad. Um, and then phase 4, this is when our anxiety can reach panic levels, right, guys? Yeah, panic, disorganized, potential panic attacks. Good job. See, this stuff is like nice and fresh in your head, which is good. So cognitive functions are disordered, emotions are labile, behavior may reflect the presence of psychotic thinking. There's also an increased risk of suicide in this 4th phase of crisis. Okay. Um, this is, I forget where we pulled this quote from. Does anyone remember where this quote was pulled from? I think she puts it like right onto her PowerPoint. Where tension mounts beyond a further threshold, major disorganization with drastic results often occurs. So I put that there for you guys. So those are our 4 phases of crisis. Now we're going to go ahead and go through some different types of crises, maybe crises. First we have dispositional. What is an example of a dispositional crisis? Do you guys remember? Job loss. Yeah. Mm-hmm. Is that supposed to say beats by? Yeah, I got you. Abusive relationships. And then what do you guys remember being some of our interventions for dispositional crises? Oh, I just copied and pasted them. You're welcome. So we would definitely need to provide physical care for any wounds in the case of domestic violence and then also screen them. We want to make sure that we get like a mental health counselor on board for support and guidance. And then we also want to encourage and empower patients to clarify needs to provide appropriate referrals. Okay. So the example, I'm going to add job loss too, so that you guys have that all on here. Abusive relationship. Perfect. Anticipated life transition. The way that I looked at these are that this is just a normal life cycle transition that like we might anticipate it, but we feel like there's like a lack of control involved in that. So like when we become that new kid, husband, stress. Yeah, I think that's one of the examples they gave you guys, right? Yeah, someone's gonna have a baby, motherhood, fatherhood, graduating soon, just whatever that shift is in our life that we feel like we have no control over. Yeah, good job, guys. And then again, I'm just going to copy and paste some interventions in that case. We would want to do their physical exam, make sure everything else is fine. We want to encourage expression of feelings regarding that life change, provide reassurance and support, and then we want to identify problems and solutions to said problems if problems arise. Okay, but I do think that this is an important nursing intervention to have during any type of crisis, to be honest. We're there to provide reassurance and support. Okay. Um, I have that. Anticipated life transition crisis, Jackie. We are here for you. Okay. Um, Now we're gonna go ahead and talk about traumatic stress. So, is this like an expected stressor or no? No, not expected. So the individual has little or no control. Um, there are some examples here, and then I'm just going to go ahead and copy and paste my interventions here. Again, I know that you guys just did this content like last week, so I'm sure they're already in your notes somewhere, but it's just nice to have it all in one place. So we have some examples here, whether it be rape or assault. In terms of interventions, we want our environment to be sensitive to the impact of trauma on the person's sense of self. We want to convey dignity, respect, hopefulness, and promote patients' empowerment to make choices in their care. Um, when they're ready, important to note, when they're ready, encourage them to talk about their experience and feelings. We want to offer reassurance and support. Okay, pretty straightforward. And then we do want to prioritize dealing with the issue. So if it is something where we need to report the crime and maybe it involves like getting that rape kit done in the ED or whatever we might need to do as nurses, just to make sure that we're also making sure that the legal side is being covered as we're caring for the patient, right? I kind of remember like maturation and developmental crises also kind of confusing me with like anticipated life um transitions, but it's more of like they like a someone fails to master a developmental task. So I guess it's associated with transitions. I don't know. I'm not gonna lie, guys. This one is one that I'm not like super confident on like discerning between this and transitional, but I also don't remember that needing to be something you had to be able to do well on this exam. Okay. But maturation and developmental crisis, it occurs in response to failed attempts to master developmental tasks. Okay. Um, in terms of interventions, we would just assist with anxiety reduction, and then we want to refer to resources. Okay. Psychopathic crisis. This is tied to pre-existing psychopathology. Okay. So if they already have personality disorders, anxiety disorders, yeah, bipolar, schizophrenia, um, that is related to a pre-existing psychopathology, okay? And then important to note, our interventions in this case would be like that. Our intervention, well, we want to encourage the patient to verbalize their trigger and then just know that they might require hospitalization if they are danger to self or others. Okay. Um, Psychiatric emergencies. Do you guys remember any examples of psychiatric emergencies? Mm-hmm. Acute SI, 5150, drug abuse, drug overdose. More so, yeah. That was acute psychosis. I actually had a patient in the ED that had acute psychosis recently. Um, so they really, when someone is in that stage of psychosis, they can really become a danger to self and others, right? So this is when general functioning has been severely impaired. They're rendered incompetent or unable to assume personal responsibility for their behavior. So again, some of the examples you guys did put in the chat already, but I already had some written down here. So acutely suicidal, drug overdoses, reactions to hallucinogens, acute psychosis, uncontrollable anger, or alcohol intoxication. So anything where they're just altered. Um, what would we think our interventions would be if someone came in a psychiatric emergency? Benzos, yeah, depending on what's going on, for sure. Any other ideas? Just think, like you're a nurse, someone's coming in, yeah, remove the harm. I like that. Therapy, I think for sure, like it would be a referral, but what is within our scope as a nurse? Yeah, patient safety assess. Yeah, good job. Maybe we need to do like gastric lavage, right? Maybe they ingested something. We can also implement any precautions, right? So I think like removing any harm from the room, that's implementing suicide precautions, right? Or suicide watch. Hmm. I think someone else put 5150 in there or danger to self others. Yeah, we're just assessing for that. Maybe we need to get a pet clinician on the case. A cocktail shot. Maybe. I'm not really sure. I didn't put that as one of my bullets, but I think it's definitely getting other eyes on the patient and then seeing what we can do, right? Okay, now we're gonna get a little bit more into crisis intervention. Um, what do you guys remember what the goal of crisis intervention is? It's like bringing them back to blank or blank. Pre-crisis, so like baseline. I also have or higher. Yeah, exactly. Pre-crisis or better. Um, Makes sense, right? Straightforward. And then of course, we want to ensure patient safety. Okay, let me see. I think we're actually really thinking through this, guys. Good job. Um, so we're gonna go ahead and go through those steps in crisis intervention. I think someone had already put it into the chat when I first asked. So someone had already put assessment, right? So stage one, we're doing that psychosocial assessment. It needs to be rapid but thorough. Okay. Stage two, what are we doing as the nurse in our crisis intervention? We already did our assessment. What are we working on now? And why do I have something different? I don't know if it's just my nose. I have rapidly established rapport. Does anyone else have that? Trust? Maybe? Yeah. Okay. Yeah, for stage two, for me, I have rapidly established rapport. Again, if your notes say something else, this outline is meant to assist you. Please don't change something that you've already been studying for something that you see on here. Oh, okay. I remember this being like out of the book. I think if you had to look at the actual like steps in crisis, I think it's out of the book. It's a little chart. Oh, it's on the PowerPoint? Okay. I remember having to go to the book for this. Um, but yeah, so stage two, rapidly establish that rapport. Stage three, we'll just talk through these all together, okay, guys? So stage three, we're identifying the major problems or crisis precipitants. So at that time, like we're kind of asking like what happened, and we see why establishing rapport would come before this, right? If we just like walk up and we're like, okay, tell me what happened, maybe they're not going to be so open to tell us. So establishing rapport makes sense to be number two. Number one, assess, make sure everyone's okay, safe to proceed. Number two, let's do what we can to establish that rapport. Number three, let's ask what happened, like what led us here. Okay, kind of makes sense in my head when I talk it through like that. Um, Identify other situations that led to that event. It could have been like a domino effect, right? And then we also just want to go ahead and start talking about um, our style of coping here, um, and like what could be beneficial to deal with these situations. Stage four. Does anyone recall what we're doing in stage four as the nurse? At least from the chart that I remember. It says stage four is when we are dealing with feelings and emotions. So this is where we're like really encouraging the patients to vent their feelings. We're providing validation. This is especially when therapeutic communication is going to be ingrained in everything we do in psychiatric nursing. But especially here where we're having them kind of walk through some of those feelings, we want to be using our therapeutic communication techniques. Um, I think there's a chart too about therapeutic communication. Like sometimes it's kind of like you repeat back and then you just like seek further clarification. Um, think of like all the journal entries that we have to do after our psych rotations and how we have to talk about a therapeutic communication like technique that we use, right? We would employ those here. Eventually and cautiously, we want to begin to like challenge maladaptive beliefs and behaviors in stage four. Okay, so cautiously. Stage five, we're headed towards, um, we're almost done. There's only seven, right? So if we're thinking like, okay, we're more than halfway done in stage five, this is where we're starting to generate and explore alternatives. So we're working collaboratively with the patient. We're identifying coping strategies that have been successful in the past, and then we're helping the patient problem solve strategies for confronting their current. Again, I think that this is going into very deep detail. I don't necessarily recall needing to know exactly what happened in each stage, but just to be able to kind of categorize where we might be depending on what we're talking to about our patient, could be helpful. Stage six, it's important to know what could happen in stage six. You guys recall? Maybe. This is when we're implementing an action plan. Yeah, good job, Emily. So this is where we're starting the plan. And then I also just wanted to make a note that we're implementing an action plan, but this is also where a shift from crisis to resolution can occur. Okay. Um, like making this is where we're breaking through, hopefully, in stage six. Okay. Develop a concrete plan of action to deal directly with the current crisis. Having a concrete plan restores the patient's equilibrium and psychological balance. And then we're working through the meaning of the event that precipitated the crisis. How could it have been prevented? What responses may have aggravated the situation? And lastly, stage 7 is really just follow-up. Do you guys remember the different time frames that you would want to schedule those follow-ups? There's like 2 specific time frames. Hmm. Just guess, guys. When would you want to follow up? Yeah, a month is one of the answers. Yeah, so a follow-up visit including 1 month. And then when you think, yeah, 1 year. Good job, Jennifer. So follow-up visit with patient to evaluate the post-crisis status. And then you want to schedule the follow-up visits to include 1 month and 1 year anniversaries of the events. Okay. Okay, we are done with crisis intervention. I think we only have abuse and then substance abuse left. This is some pretty heavy content, okay, guys? So just keep that in mind. But it is important that we go over it and that we're equipped to assist our patients, okay? So, what do you guys remember to be factors that influence abuse? If you don't already have your notes in front of you, go ahead and pull those up, guys, okay? What can influence abuse? What could lead someone? Yeah, genetics, job levels, neurological disorders. I don't have that, but I see what you mean there. Biochemical. Like it could be learned. Like they children can imitate their role models, so the people around them, if they yeah, sociocultural, good job. And then the first bullet point that I have here is like unmet needs for satisfaction and security. Um, it can kind of lead to is the screen zoomed in enough for you guys? I just realized it's kind of zoomed out. Is it big enough for everyone to read as I'm putting stuff in? Hopefully it's okay. No one's saying it's not. Um, okay. So then we have our unmet needs, and then that can lead to aggression or violence, because that can like boost ego or validate someone who might partake in abuse. Learning is when like their role models are doing it, so they don't learn any differently. Sociocultural, so that's where we're looking about like family dynamics, right? And exposure to violence and then genetics. Um, do you guys recall who the most commonly abused group is? Who is the most commonly abused group? Men or women? Sorry, I misunderstood. Keeping almost doing something. Close the door, Bob. Mom props. Okay, so yes, women. And then just some bullet points on that. It could really be like all ages, all races, religions, cultures, education, socioeconomic group. Like it's not really defined to any small like more specific like factor to that, but it does say that the most commonly abused is women. Doesn't mean that men are not or others. Um, it does say that victims typically have low self-esteem. They often take blame for their batter's actions, and then usually there's some feelings of guilt, anger, fear. And then when they talk about abusers, who are typically abusers? According to this content, yes. And then do they typically have high self-esteem or low self-esteem? They usually have low self-esteem. And then I just made another bullet point that I had in my notes was that they're like pathologically jealous or possessive. We're gonna go ahead and talk about the cycle of battering really quick. So in the tension building phase, are you guys kind of familiar with this cycle of battering? I remember it being like a graphic. Honeymoon we get to, but first we have tension building phase. So this is like the precursor. Yeah, this is the precursor of the actual like battery incident. So when we're talking about tension building phase, we're saying that like the abuser is becoming angry. But then like after they lash out, like they're like very quick to apologize. The victim may become very nurturing and compliant, anticipating every whim and effort to prevent. I don't know if it's like specific to who's who because it can very much be anyone. So we're gonna say their anger from escalating, okay? Um, the victim really might just try to stay out of their way during this phase. Now we have the acute battery incident, battering incident, and this is considered the like the most violent phase in the cycle. Um, but it's also the shortest. Do you guys remember? I don't remember needing to know the time frame for each, but for acute battering incident, I did say that it can last up to 24 hours. Yeah. I have it in my notes here. I don't necessarily remember. It doesn't scream at me as like exam question type stuff, but maybe just important to know that it's also like the shortest part of the cycle, okay? So it can last 24 hours. Um, it often begins with like the batterer justifying their behavior to themselves, and then by the end of the incident, um, they don't really understand what's happened, only that like enraged, they lost control over their behavior. Okay. And then lastly, honeymoon. This is we already kind of talked about it, aka undoing. Um, what happens to our batterer during this time? Are they still like super angry and like ready to snap? You guys recall? Yeah, exactly. They're very loving, they're apologetic, yeah, gift giving. They promise they'll never do that again. Okay. Sadly, I remember there being a bullet point where during this time the abuser might think that like um they already like kind of taught them a lesson. Um and then they believe like the victim will act up again, quote unquote act up again. And then the victim's also like desperately wants to believe that the abuser can change during this phase. Okay. Um, why do they stay? Do you guys remember? This I remember being important to know. Why do they stay? Fear. Fear of retaliation. What happens what happens after that abuse cycle? There's a very high risk of blank when trying to leave. Yeah. Yeah. It's really sad. Really, whoops, I messed up. Fear retaliation, highest risk of dying when trying to. There's also like financial reasons, and then sometimes when there's children involved, right? important to note. Let's see how far along we're at. Ooh, we're almost done, guys. You guys are just killing it in the chat. There's also like way less content in this quiz, which is really nice. So we're gonna go ahead and talk about um the content for child abuse really quick. Um, we have physical abuse, emotional abuse, physical emotional neglect, okay, and there's also sexual abuse. Um, but what are some signs and symptoms of our victims of physical abuse? Like just as a nurse being able to recognize it. What are some signs? Yeah, bruises. Maybe they're all in like different healing stages. Broken bones. Flinching at adults. Yeah, flinching, shrinking. All really, really sad. Um, but something that sadly like we have to have an eye out for, right? I think there's actually like a TikTok thing going on. I think it's even like a nurse creator or something that she's like an and she does something and like her like child kind of flinches at her, right? Yeah. Um, again, you don't know like the whole situation, but yeah, I remember that being like that is a huge sign of abuse. Like if they don't trust that they're not gonna get hit, you know? Whereas if they haven't been hit or something, like that really wouldn't phase them because they don't think that there's like danger associated. Like, is she in jail? I have no idea. I have no idea. I'm really trying to limit my TikTok until I'm done with this class. But yeah. Um, oh jeez. I will definitely go down the TikTok hole to figure it out. Um, the other ones that we didn't necessarily have in the chat, which is important to note, the child might not want to go home, and then there can also be like abuse of animals or pets. Um, when we're looking at like signs and symptoms, or just like what are we, if you're thinking about like the abuser, like what behaviors are we expecting from them? You guys remember? Like what happens if you're asking them like, so what happened here? If we're talking, if we're referring to like, yeah, like they're making excuses, yeah, like there's no explanation. Exactly. Um, it could be conflicting, right? Compared to like what the child tells us. Um, sometimes they can be like overtly harsh, or like they could even describe the child like they make it seem as if the child is the issue, which is really sad. And then abusers can also have a history of abuse as well. It kind of goes back into that like that learned like when we scroll up here to talk about, you guys remember what I'm talking about? When did we talk about it? And it could be learned or like their role model. Hmm. It's on here some. Oh, here we go. The factors that influence, okay, so it can be learned. They also experienced it, so um, they might not know the difference, even though they should. Um, if we're talking about emotional abuse, what are some signs and symptoms of emotional abuse? It can be hmm. I mean, I get what you mean. I don't necessarily have it on my bullet points, but I get what you mean. They might be like lashing out if they're experiencing repair, repeat. Like what are some signs and symptoms of children that are being emotionally abused? It's okay. Signs and symptoms of children that are emotionally abused. Yeah, I think insecure is very applicable. Depressed. So maybe they attempted SI or have thought about it. Depression, anxiety, low self-esteem, not attached. Good job, guys. You got all of the ones that I had down. So extremes in behavior as well. So they can be really demanding, passive, overly compliant, or aggressive. There can also be some delays in like physical and emotional development. Um, I'm just gonna go ahead and copy and paste these. I don't necessarily, it's all kind of overlapped, but they would like an abuser would like overtly reject the child. They're constantly blaming or berating the child, and then they're just completely unconcerned. So that's when we're thinking like emotional abuse. Physical or emotional neglect. I do remember something about this one. So, what are some signs and symptoms of physical or emotional neglect for the child? What does that child, what would we recognize? A lotus, yeah. So we're thinking like poor hygiene there. Mm-hmm. Yeah, a lot of absences. Mm-hmm. Underweight. Yeah, I see that. They're always like stealing food, right? Becoming absent. Maybe they're starting to partake in some risky behaviors, inappropriate clothing for weather. Yeah, those are all really good examples. So just like sad to say, but very general, like they're just not being taken care of, right? No dental medical care. Yeah. So frequently absent, begging for or stealing food or money, lack medical dental care. Maybe they need glasses, they don't have glasses, dirty clothes, loaders, which we said already. Maybe they're partaking in some risky behaviors. Maybe they're abusing drugs or alcohol, and then they're stating that no one's at home. Um, Again, I'm just gonna go ahead and copy and paste these as well. I don't think that any like signs and symptoms of abusers are like specific to the type of abuse, but just some slight variation. That these abusers would be like apathetic, they would just be indifferent towards the child, and then they also might be abusing alcohol or drugs. Okay. I went ahead and just left my bullet points for the sexual abuse portion. This is all really disturbing. I don't know if you guys had a hard time reading. I'm sure everyone had a hard time reading that article, you know. This is actually, I mean, not to like take us away from our review, but I was actually really interested in doing pediatric nursing until we came to psych. And I started to think about like being the first set of eyes that might recognize some of these signs and symptoms. And yeah, I couldn't manage that. So I already have some signs and symptoms here listed for you. And then just from the abuser, like they would have inappropriate relationships, controlling or protective, secretive and isolating, and then it might they'll say it's like favoritism or like do good living. Okay. So that concludes our abuse, the human abuse section. I did just make an extra note when it comes to nursing priorities. Um, the priority is to meet the medical needs or the safety of the patient before we engage in psychosocial. So we have to think ABCs, right? Physiological before psychiatric safety. Not that we aren't going to get to the psychiatric safety, but in the immediate, we are worried about physiological, okay? And then there is a note that like care if we were to be doing an assessment and we locate like a bruise or like a questionable lesion, whatever it might be, um, a caregiver can deny having a picture taken, okay, of the child because they're minors. So it's very important in our role to make sure that we're using like proper documentation and that we're being very thorough in the documentation so that like we paint a picture of what we're seeing without an actual picture. Does that make sense to you guys? So just note, caregivers can deny having the picture taken it's our responsibility to make sure that our documentation is on point and that um it paints the picture of what we're seeing. Okay, so be very like overly descriptive. Um, I think all we have left is some substance and alcohol abuse. Okay, guys. So we're just gonna go ahead and keep on keeping on. Um, Substance abuse. How do we define addiction? Actually, I don't even know if this is definition, but it just kind of puts it into perspective. When it comes to addiction, there's like a physical or physiological like dependence on it, right? Or can cause distress if they don't have it. Um, when we're I already left that in there for you guys. Sorry. I think I was honestly thinking we were gonna run out of time, so I just left certain parts in there for you guys already. So when we talk about like physical dependence and tolerance, um, they'll need to like increase the substance to produce a more desired effect, and then physical symptoms would go along with it. When we're talking about physiological dependence, that refers to like having the desire to use a substance to produce the intoxication or high to avoid discomfort. So physical dependence, um, they'll need to increase the substance to produce the desired effect. Physiological is just to use it to produce that intoxication or high. Okay, so make note of the difference. And then in terms of withdrawal, I think you guys just did Jody Peterson, so this should be pretty fresh in your head. But that's when they're developing the signs and symptoms that occur with abrupt reduction or discontinuing of the substance. And then it's usually substance specific. Okay. That's all I really have for substance abuse. But we just want to make sure we're always screening our patients. Okay. And then that's why it's also important to note when you're giving like SBAR, when you're back in med surg and stuff, you're always going to want to mention if there's any like substance abuse issues as well. Um, as we talk about alcohol abuse, do you guys recall some of the risk factors for alcohol abuse? Genetics. Yeah, thank you. That's the main one that I have. Um, Genetics, family history, sociocultural, socioeconomic. And then in terms of effects of alcohol abuse, what are we thinking? What does alcohol abuse cause? Oh yeah, cures for sure. Like peer pressure. What can alcohol abuse cause? And what's the big one that you guys have probably already seen in clinical? Have any of you guys had, yeah, cirrhosis? Oh, you guys have seen withdrawal already? I actually didn't see withdrawal until I went to the ED. Yeah, pancreatitis can also be part of it, but the big one that I have in here because psych, I mean, we still learn some physiological stuff, but not too much. But yeah, I just really wanted to make a note that like there's risk of the cirrhosis of the liver, and then there's also a risk of cardiomyopathy. Um, Important to note, have any of you guys had um a patient with encephalopathy related to cirrhosis of the liver? Yeah. So that was like I think I took a patient in 220 that was in for hepatic encephalopathy. And if you already cared for one of these patients, that will help you in 232 because you learn about cirrhosis. Yeah, in 220. And you like think of that whole care plan, right? Like the ammonia level, the lactulose, everything that you do. Uh-huh. Yeah, abrupt cessation causes acute withdrawal leading to CNS saturation. Yeah, definitely. I see what you mean there. I'll add it. And then Korsakoff's psychosis, we get into it a little lower, but this is like confusion or like loss of recent memory. It can also be caused by alcohol abuse. Okay. What are some of those signs and symptoms of alcohol withdrawal? You can already probably think of that assessment that we have to do, but what does our patient look like that's going through alcohol withdrawal? Tremors, nausea, anxiety, sweating, high BP, yeah. Also high, is PR pulse rate, heart rate? Yeah, high heart rate, hallucinations. Yep, you guys got all of them. Headache, right? That's on our CWA. What does the headache feel like? Is it a band squeezing your head, right? You guys remember that? Good job. You guys got them all. The ones that I already had written in here are delirium tremens. So this is something that we're looking out for in cases of severe withdrawal. So it's all the symptoms that you already see here, but they're like more extreme. And there'll also be like profound confusion and disorientation, maybe even some like delusions and paranoia. We also have Wernicke-Korsakoff syndrome, and this is related to vitamin B1 or thiamine deficiency. Um, this has like confusion, inertia, so like lack of energy, low BP, and even possibility of coma. Okay. And that's why as we get into like the management, I did put like thiamine deficiency here. So if we're talking about management and how we might give something, maybe we're trying to prevent something. Okay. So just start putting those things together. Um, I think I don't know. Okay, so what is our assessment for withdrawal? You guys remember? You guys just did it. The something score. See, well, good job. So that's our assessment for withdrawal. And then what's our assessment for like possible alcohol abuse or misuse? Yeah, good job. That's our cage assessment. You guys remember those 4 questions that go along with the cage assessment? What does the C stand for? You guys remember? Have you ever felt that you should cut down your drinking? Good job. Have people annoyed you? Yay, you guys are doing fill in the blank. Have you ever felt bad or guilty, about your drinking? And then have you ever had a drink first thing in the morning? Eye opener. Yeah, good job, guys. So you guys are all well versed in your assessments. Just make note that 2 or more yeses, not necessarily for like the exam question, but just in terms of this assessment, 2 or more is positive and they require further eval treatment. Okay. There are some meds that we can use to manage um alcohol abuse. So, do you guys remember what might be given? Especially it's like a first line treatment of withdrawal. Yeah, disulfiram is one of them as well. But there's a first line, yeah, benzos are the first line treatment for withdrawal. Um, and then just what I learned in the ED is after withdrawal. Oh, really? I don't know why in the ED I learned that first line was benzos. That could be wrong. Anything just to chill them out because we don't want them to go into seizures, right? Um, and this is why, okay, this I remember being important. is considered substitution therapy. So they would still get like a CNS depressant, which is why they're receiving a benzo. Okay. And then I think someone had already said disulfiram or antabuse. Are you guys aware of how that works? Is anyone familiar with it? Yeah, they become like violently ill. So it's like a deterrent. Yeah. Good job. So that one works as a deterrent. And then those are like the main two. And then the one I really also wanted to note for you guys was the one I also wanted to note for you guys is that thiamine, the multivitamin. Again, when we're thinking thiamine, what are we trying to prevent? Okay, so we give thiamine to prevent Wernicke-Korsakoff, okay, or hepatic encephalopathy, okay? So just think about that. It's part of the care plan to prevent those things. There's also naltrexone. Um, it just reduces like the pleasure gained from alcohol, and then Revex can be used to wean off. I don't really recall these being too important, but I know that this is something about like it's the deterrent, and then this is oh I thought I didn't I highlight this? Maybe I did it. Substitution therapy. You replace a CNS depressant like alcohol with another CNS depressant. Okay. In terms of patient education for someone that might be going through alcohol abuse, we want to be talking about those triggers. That's something that you guys are going to see a lot of. We want to identify triggers and healthy coping mechanisms instead. So finding things to substitute, the substitution part again. Okay. So when we have a patient that's coming in like in withdrawal, we want to do something called substitution therapy, which is why we give them a benzo because alcohol is a CNS depressant. So we treat them with a CNS depressant so that we can kind of like titrate them down so that it's not as severe of a withdrawal. Does that make sense? No problem. So substitution therapy, it's an alternative to CNS depressant. Okay. So patient education, we're talking about triggers that lead to alcoholism. There's things to substitute. So whether it's progressive relaxation, tensing and relaxing, or deep breathing, we can also refer them to AA groups. After all, we've all attended one now at this point, in this course, right? So we can refer it to them. We also know part of that is that we had to go and find our own meetings so that if we were to be providing that patient education, we know how to instruct a patient to find a meeting, as well as good nutrition, and then we can always refer them to counseling. Okay. Um, that's actually all I have for this outline. Like I said, it's not as much content as the other exams. I think it's only like 30 to 35 minutes. I mean, questions this exam. I actually think it was only 30 for us.